So we were looking at a lack of protected time for researchers, and a few of the points, I suppose, to start off with is how it depends on the role that the researcher has. So I kind of mentioned in the UK there's a lot of roles that are kind of split between research and clinical, where there might be 80% clinical duties and 20% research. I know in psychology there's a few select positions like that now in Ireland where someone is split between a university and a clinical setting, but that probably solidifies protected time into their contract and role. What else? So, yeah, I guess what's the solution to protected time? So I mentioned ethics, like that whole process in my own experience has been a very time constraining endeavour, and streamlining that process would definitely help. In my experience anyway. Just let me see what else. What is it? So I suppose funding for the researcher, I guess, is a huge barrier. Like, if I suppose an organisation is going to give someone protected time to do research, they're going to have to pay them for that protected time. So it's all resource dependent. What else? So we have like fitting the research around normal job responsibilities. So whether that's clinical duties, we talked about like nurses, I suppose, doing rounds in the ward, and research duties maybe having to be done after all that clinical work has been completed, and it's not obvious how remuneration for that work, or what incentive is there for someone to do an ethics application or write a publication after they've already seen 30 or 40 patients. So yeah, efficient. It's just 3 minutes, is it? Yeah, that's probably it. Yeah.
Thank you, Rory. Thanks very much. So we were looking at research infrastructure, the barriers and solutions. So one of the barriers was funding. That came up again, and not having a researcher, not having a lead, really, someone leading this, a lead researcher, research officer. And one of the solutions for that was developing a business case for a research officer, and then who would fund that to have a position like that. Clearly it's needed. And then one of the other barriers was limited experience. People feeling that they didn't have enough experience to do this, like Kasia was saying when she started in her role. So having access to expertise through universities, through other hospices, the HSE, so having that collaborative approach, a lack of knowledge of the governance structures as well, and what's required for that. And how to generate interest as well, because people are really busy, and this has come up a number of times today. People are so busy clinically, so that interest, and that's where that lead person is kind of crucial for really bringing it along. A lack of guidance in accessing expertise, and we've spoken about that. And something really interesting that came up from a colleague from Kasia in Northern Ireland is they have their research policies, and we were all like, research policies, okay. We've educational policies, but your actual research policy, that it's built in as a research policy. So that was really interesting, and there was a lot of discussion around that at our table. Another barrier is that there's no clear pathways. So for people filling out, you always hear when people are filling out their ethics forms that, and I know this is the plan as well, with the reform, that it's going to be more centralised, but you have to fill out so many different forms. It's very cumbersome. It's, so it takes a lot of time. So I think that'll be really useful. part of the solutions as well is identifying research priorities and working together. And you know, Catherine said it earlier, and it made a lot of sense. Having 2 or 3 big projects where maybe hospices are working together rather than all the little projects that are going on, and how interesting that could be. We have the All Ireland Institute. We have, you know, the All Ireland Institute of Hospice and Palliative Care. There is stuff, you know, there's already, I suppose, groups in place and committees in place that maybe we need to use in different ways. So there's a joined up approach to that, those formal network, where there's a repository of expertise and, you know, central data. Yeah, sharing what we have. So some hospices or areas might have librarians and others don't. So if we're collaborating, that can be shared as well. So really collaboration. And the big takeaway was a lead, someone who's going to lead within the organisation. Was there anything else? No. Thanks.
Yes, that's interesting about research policies, because we're talking about research strategy and all that stuff that goes with that, but research policies for organisations would be very helpful. Okay.
Thanks, William. It's interesting in that even though it's funding, it's the same kind of ideas that are coming up in each section. So ours wasn't different, even though it was looking at a different aspect of things. So we dealt with them kind of separately. So initially to talk about the barriers, we talked about limited resources, what seems like quite a small pot for funding. There's lots of people with very good ideas applying with competing interests. That potentially the initial applications for funding can seem daunting, the amount of work involved, the administrative task of it, and that's very much regardless of the outcome. To keep your head up to try and face into further applications, potentially after a failed call, is very tricky. The complexity of application criteria and the knowledge required, that there's certainly a skill and an expertise that's needed to apply for a funding call. Again, we spoke about this comes up both on the barrier side and on the facilitator side, because sometimes there can be a lack of collaborators for a particular project that you might have an interest in. Sometimes about timing and trends, you know, and that you can really have to be on trend with a certain research idea, or be timing a project really that is on vogue at that moment to be successful with certain calls. And we also spoke about how it can be tricky to judge the specific costing and timing for funding calls in application budgets when there's such complex interventions that we're researching. And so just to look at some of the solutions then that we discussed, I suppose the big one that came up, as everybody is saying, is about collaborators, you know, and seeking collaboration as we're in the hospice sector, sometimes smaller individual centres that are focused on smaller projects. So we talked about collaboration within our own organisations, and then we also talked about strategic partnerships, looking potentially outside the traditional palliative care researchers. So looking outside our own multidisciplinary team into the oncology sector, the organ failure sector, to seek out opportunity and experience within their sectors that some people would say are more advanced in and more consistently applying for cause. Dedicated personnel, and I suppose everybody, you know, has spoken about Cash's role and how that's such an interesting role for us in the south and looking north. Developing networks, and we talked about developing networks within the palliative care sector, but also within the private sector, keeping abreast of trends and how that comes up with collaborators again, and attending events like this, building relationships, strategies we thought about as well to demonstrate research impact, and how sometimes we're very good in palliative care demonstrating the human side or the clinical side of the story, for example in Palliative Care Week, and how impactful that can be, and maybe that we're not selling the research that we are already doing to that same effective way. That we can really sell the human story, but that we haven't cracked how to sell what we're doing in terms of the research that we have, and how that in turn then builds into your funding applications. That was a few of those bits.
That's great, thank you. I think it's very important just to highlight that keeping the head up whenever you're not successful with funding. That's a really important point. And looking outside of the palliative care sectors is really, really interesting as well. So really good points, thank you.
Thank you. So we're table 4, funding and research strategy. So once again, many of the things that have already been discussed, we have similar. So we looked at the barriers and then the solutions. As we've already mentioned, that awareness of where to access funding. One of the things we had said that funding often goes to the academics. The application process is difficult. Our approach is often splintered, and we just need to be more collective in that approach. Research question can be difficult. There's a competitive process, and it's important to carry out research that is likely to impact patient care and not just something that somebody has thought as a good idea, but that it's actually going to make a difference to the care that we're delivering. Other specialties have it established, and we tend to have to align with them, such as oncology. We have a lack of infrastructure in hospices then to support our research, and there's very often a policy and political agenda behind the funding, and we have a lack of top-down support, and it's felt at our table that we're firmly stuck in a bottom-up approach. So then, just looking at some of the solutions, a more collaborative approach between policy, research and clinical staff. We need to influence our leaders in hospices, our chief executives, our policy makers, and we need to put forward a very strong voice about dedicated research positions and the importance of having them. We need strategy for clinical research. That academic mentorship that Cassie had talked about is very important. Job plans should include protected time for research, and there should be a monitoring process in place through KPIs or whatever for research to make sure that everybody is participating in it. We've heard that need for proper investment. We should look at other organisations to see why they have been so successful, and encourage all staff to have a critical mind, to bring research, to bring their questioning into research. And HRB applied partnership funding as a model, so I'm not sure HRB is Health Research Board, and meaningful research which adds value, which is directed by knowledgeable users, such as our PPI involvement. Anything else?
There's definitely some really good points in there. That academic mentorship is definitely coming across as a really sort of good enabler within the hospices. And another one with the monitoring processes through KPIs would be very useful and motivating maybe within organisations.
Thank
Thank you. So we were looking at funding and research strategy. So we began our discussion with a kind of a review of funding sources, and these will all be familiar to everybody in the room, but if we were to just run through them kind of in broad topic headings, obviously there's philanthropic funding sources, there's competitive grant calls, whether they be national or international, there's calls unique to the island of Ireland, whether they be cross-border or Ireland-US calls. There's industry, there's infrastructure awards, and then there's obviously funding sources through, say, core service provision in universities, academic pathways, and so on. But it was really where, I suppose, some of these points brought us in the discussion that we started mining down. So I suppose if we were just to take a relatively straightforward one, like philanthropic funding sources, what came up as part of the discussion was that now in Ireland, we've fortunately moved to 100% of core services being funded by the state, which obviously frees up philanthropy, fundraising by the hospices for research and innovation. And we contrast that with Northern Ireland and the financial constraints that their health service is currently experiencing. And instead of that being a point of difference, we should look at that as a point of support and mutual assistance, because both in terms of the comparative approach, whereby we can show what's working in the south and the extrapolating to the north, but also then the resonance that if you're thinking about trying to build research in a very resource-constrained environment, you want to focus on clinically meaningful research to get the engagement, and that is something that then would really bring that back to reality for us in the south. So, just at the outset, a real reminder to us of the benefits of the all-Ireland approach to the all-island approach, sorry, just in case that came out wrongly, the all-Ireland approach to research. And then I suppose the one that we kind of honed into then was the infrastructure awards, because there currently seems to be a little bit of a focus in Ireland in terms of funding focusing on developing core infrastructural capacity. And that's important to us because that really resonated with obviously the state of research in Ireland. And we wondered whether that would be something where there would really be a common ground for agreement across the island of Ireland, because if we look at research themes and research topics, people will have particular areas of expertise or interest and so on and so forth. And why it's not impossible by any manner of means to broker agreement, and that's the point of the Palliative Care Research Network. I suppose the fact that we are all in a common boat of lacking infrastructure gives us a very common starting point. And the idea of learning from the UK and AIIHR experience with Christina in terms of, are we passive recipients of these grant calls and awards, or do we move to being active influencers? And how, again, collectively can we actively influence in something like an infrastructure call if one were to be able in a position that we would say we have common agreement across organisations, north and south, around about what a research infrastructure would look like, and then a collective agreement as to how we would engage in multi-site research, not necessarily signing up at this point in time to any one specific trial, but a collective agreement of a quid pro quo. We get infrastructure, but we commit to a certain amount of throughput through studies and so on, the ICORG and other type models. So we felt that was a really kind of an interesting potential idea that could come forward in terms of a position paper strategy going forward, and really that piece about strength in numbers and collaboration, which both would grow commonality but would also allow for individualisation, but the bottom line being in service to patients and the communities. Thank you.
That was great. Thank you, Karen. Some really, really good ideas there, and that sort of collaboratively working together, that all-island approach to sort of see what you can do to work together to develop that infrastructure. As you say, it's a common theme throughout today. Okay, so we have our last table now. Thank you so much.
Thank you. Most of what's been said, we've really sort of said the same as well. Ours was to look at collaboration, and we thought initially, what do we mean by collaboration? So, we looked at what were the differences and the mutual understandings, and looked at the culture and the expectations around research. So we looked at the barriers first, and we said, we looked at time commitment. That seems to become up quite a lot of time obviously a few times people have said this, and that seems to be one of the most common reasons why people feel with the time, on the clinical area in particular, that they haven't got time to commit themselves to research. In addition to that, we said to looking at the lack of awareness, and that goes with cultural differences. So a lack of awareness potentially at a local level, or from the ground up, as people were saying, that people really understand research and how to engage in it and the process, but also looking at the differences and lack of awareness of each different cultures. Do the clinicians really have a full understanding of the academia or the academic side, and do the academics understand the clinician side? So sometimes there's differences there that people need to overcome. Another major barrier that we thought that affects research, and say it as it is often time, as we said, but also money. So looking at the funding and where do you apply for that funding, and where does it go? Who's going to give you that funding, and do they have other priorities where that money should be going within the services? The next thing we were thinking was as well, a barrier can be competition amongst particular organisations. And again, that's involved with the money too. You know, somebody might have funding and somebody might have less funding, etc. And there is potentially a healthy competition between different organisations as well in relation to looking at research and putting their own name on the map. And also, ethically, I can't remember. It's about ethics. So looking at what we were saying here with these, some of these same points that we've mentioned as barriers can also be turned around and looked at as enablers. So, for example, the networking, the working together, rather than against or separate from each other. If you do one, as we've said before, one large piece of research rather than small individual pieces, would not only be more time-consuming, more open to other areas that we can understand different cultures and different areas where we're coming from, but also from a time factor. The more people that are involved and collaborating and working together, the less time an individual will need to specifically spend on that whole time working with that research. And it should be more beneficial from a financial perspective as well. Creation of new roles was another enabler we thought. So we were looking at, again, looking at the clinic, if you could involve more that clinical academic role with regarding teaching and supporting with research. And also we've mentioned again what was mentioned before about the strategic objectives, including research as part of your overall strategic plans and for your organisations. Also looked at enabling would be partnership arrangements, looking at a mentorship, that academic mentorship role that was also mentioned previously at one of the other tables. So I think that's about it, is it? Is that okay? Anything else? Okay, thank you.
Thank you. Thank you, everyone. So that brings us to the end. Thank you so much for engaging in a really excellent open session. You've given us lots to work with and to think about. And now I'm going to hand over to Karen.
Hello. So I realise I'm standing between you and home, so I will be brief. Just some key learnings from today. When I was listening to Professor Fall, she told us about the importance of hospices engaging in research and detailed how it can directly lead to improvements in patient care. I think we'd all agree with that, and thank you, Christina, for today. Professor Karen Ryan explained the academic health science system and how the interlinkages between research, education and clinical care have multiple benefits. So thank you very much, Karen, I definitely learned lots during your presentation. Cassia spoke, maybe she's hiding from me, spoke about her experience, about her journey as a research nurse, and how it compares to undertaking a ultra marathon, and that she finds it both challenging and also very fulfilling. So thank you, Cassia. The engaging public and patient involvement contributors panel section, chaired so ably by Will, who's actually unfortunately left, so I can't, but I'll thank him again, with contributions from Mary and Janet. For me, the session showed the importance of ensuring that engagement with people with life-limiting conditions, carers and the public is meaningful, and also that we need to support researchers with engaging with PPI, so it's a two-way street. In the Making Research Governance Easier, which Una so ably chaired, thank you Una, Una highlighted the importance of having clear ethics and the processes around it. Gorel highlighted the ethics developments within the UK, including within Marie Curie, and Mary highlighted the big changes in the HSC with the new ethics structures being rolled out in the regions, and I'm sure we're all really looking forward to seeing how they are going to work in practice as well. It was also great to hear from Catherine Walsh on the barriers, opportunities and resources for hospice engagement in research based on a study of one of the best areas in the UK, which is Lancashire. Obviously, that is completely true. My home county. And it's fantastic to hear about the findings of the survey, along with hearing about the wide range of resources that they've developed to support research in hospice, and I'm looking forward to looking at their website further, Palcare NWC. We always try and join up with great sources, so I'm sure we'll be joining up with that, Catherine, shortly. And Catherine also challenged us to educate ourselves about how to undertake large-scale studies together, and we in the Institute look forward to supporting that. So I suppose in the session that we've just done, there's loads of learning, loads of thoughts, and I know Mary and colleagues, we're going to be developing a position paper on this, and then we're going to be consulting you as part of that process, because we really want today to have an impact on research policy, research strategy going forward, and on the work of the Institute, I suppose, as well. So yeah, today is one step along that journey. So, but it's so I've just a few thank yous, and I haven't made a note of these, so they're off the top of my head. Just want to thank all of you. Well, firstly, I want to thank all of you for sparing the time. I know everyone is very busy, and just a big thank you for sparing the time out of your busy diaries to coming along today. Really does mean a lot to us. I'd like to thank all of the speakers. You've made fantastic contributions throughout the day. And last but not least, I'd like to thank my colleagues. So I'd like to thank Jackie for doing such a fantastic job with the survey and hosting that last workshop, and looking forward to continuing to work with you. I would like to thank Jane and Marion and Julia, who's outside, for supporting with the organisation. But last but not least, I'd like to thank Mary for all the work she's put into today. Mary has really very much guided today, so thank you to all. So without further ado, everyone safe home, and thank you so much for today.